Tony Young, National Clinical Lead for Innovation at NHS England, to come and join us. Tony, thanks very much for coming to talk about your work in NHS England. I think it's fair to say that you've become something of a legend through the health service. Everywhere one goes, one hears about Tony Young. And a big part of that is the Clinical Entrepreneurs Training Programme that you've established. So could you start by telling us where the idea came from and how it's worked in practice?
Sure, and thank you very much for that kind introduction. I'm not. I think a legend can go both ways, can't it? I think it might be good that you didn't reference that, so that's I'll take it as a good one. For those of you who don't know me, I'm a practicing surgeon in the NHS, still on the front line. I was on call for 72 hours this weekend, so forgive me if I'm slightly jaded. But also the National Clinical Lead for Innovation. So someone in the centre at NHS England who, in fact, most of my life I've fought the system to try and get it to be more innovative and entrepreneurial. And 5 years ago was invited by Sir Bruce Keogh, our medical director, to come to the centre to say, how can we drag it in this direction, Tony? I had already, as a junior doctor, alongside my PhD, I'd done 4 medtech startups, raising about £5 million of private sector funds to drive them forward. So I was someone in the system who was a clinician. I'm an academic too. I'm the chair of medical innovation at the medical school at Anglia Ruskin University. But also with that academic, clinical and entrepreneurial background, there weren't many people, I think, in the NHS who got that kind of track record. In fact, if you can see the scars on my back from trying to be an innovator and entrepreneur in healthcare, because people very often don't want to change. So when Sir Bruce appointed me, he said, come and show us how to do innovation enterprise. Let's try and help make the health service a more innovative place where this inequality of, in some centres that the latest, greatest things have been taken up and just down the road they haven't. But of course he gave me no money or no formal power to make the change happen, as is the way in the National Health Service, many of you will know. So the opportunity then came to pitch policy, to get, when I started, being, as a frontline surgeon, and when you go into an organisation, you have to kind of get the feel of it, understand how it works. I hadn't worked in central government or arm's length bodies before much. So, and when I was there, junior doctors started approaching me, and a couple in particular who'd raised about £5 million for their own digital health startup. And they said, we've been told quite clearly that we can either be doctors or we can be entrepreneurs, but we can't be both. And they were giving the choice of carrying on. One was a vascular surgeon and one was a plastic surgeon. And they were told, you can either carry on in training or you can be entrepreneurs, to make your choice. So they both left medicine. But of course, if anyone here is a clinician will know one of the reasons you go into healthcare is because you're passionate and committed about making a difference to the person who's in front of you, their family, their loved ones. But when you're also driven to be an entrepreneur, you want to try and impact the lives of thousands, tens of thousands, millions of people. And there's a paradox here. How can you balance having very real impact on people's lives in front of you and actually impacting the lives of many people? And lots of young clinicians said, well, actually, I'll be an entrepreneur, and then I can do both and stay in healthcare. So when I took Sir Bruce to see this young startup, Touch Surgery, or Digital Surgery as it's now known, who've gone on to raise well over £60 million, I think, in various funding. And he said, Tony, we've got to do something about it. Let me know what your thoughts are on a paper. So I wrote the briefing paper for the Clinical Entrepreneur Programme. We'd supported clinicians to be leaders, to be educators, to be researchers, but we hadn't traditionally supported people who wanted to be entrepreneurs in the NHS. So around 3 years ago, we launched our first cohort. We're now just finishing year 3. We have become the world's largest entrepreneur programme in healthcare. We currently have over 340 frontline clinicians, doctors, nurses, dentists, allied health practitioners, clinical scientists, pharmacists on the programme. And by September, we'll have well over 500 as we put the new cohort in as well. And they tend to stay with us for multiple years. There are about 10 of them in the audience here today who've come with me to the FD Digital Health Summit, because lots of them actually have great ideas in digital health. So it wasn't so much that I came up with a great idea. I was in a position where I could hear from the front line and prepare the relevant sort of policy paper that needed to be done in the centre, understand how to win hearts and minds and make things work. And the key thing was not to ask for money. If I'd have asked for money for this, everyone would have said, hang on, we should be spending money on hip replacements or knees or new things for patients. Why are we spending on startups and entrepreneurs? But actually, we can't rely on the latest, greatest things to come out of somewhere else. I was very interested to hear the German health minister speaking earlier about how he wants to take forward innovation and entrepreneurships and start up and support them. You know, in Britain, we're a nation that's got a proud and long history of inventing lots of great things, but we've been less successful perhaps at commercially exploiting those and innovating those. You know, whether it's the CT scanner or the MRI scanner, the computer, the television, all invented in the United Kingdom but actually commercialised abroad. So our patients in the NHS would be losing the benefit of first-hand innovation if we don't support that start-up ecosystem and take it forward. So within their first 2 years, by the end of year 2, we had about 240 entrepreneurs on the programme. They'd created 113 startups. They'd raised £118 million between them. They'd impacted about 14 million patients and professionals that we could count. And we'd given them no money from the centre, just our blessing and support, a commercial coach and mentor. They could do less than full-time training if they wanted to take that forward. We connected them to customers and funding, lots of networking events, that's why some of them are here today, but also a whole training programme, like an accelerator bite-sized boot camp that we split into 7 or 8 days across the year so they can carry on working in clinical medicine, but still learn the core fundamentals about being an entrepreneur. You know, as a doctor, I was never taught about profit and loss and you know, balance and cash flow, as well as legal and regulatory things about being not just a company director and the responsibilities you have, but also about regulation in medical affairs, how you sell into healthcare, how you market things, how you brand yourself.
Right.
There is no lesson for that. So it's, yeah, so by year 2, so Stanford University, which have a fantastic biodesign program, it used to be the world's leading entrepreneurial training program in healthcare, but by year 2, the NHS had beaten Stanford's 15-year data. And I felt really proud, and I just said, well, all we've done is given permission to our frontline staff in the NHS to step forward and say, how can we help support you in delivering that solution? So I wouldn't say it's me that's done it, I would say it's our amazing frontline staff.
Amazing. And how many of those ideas have reached the market? It's obviously quite early days.
So when you look at the startup world generally, my experience is it's way higher than 9 out of 10 fail, and I'd say probably between 30 to 40% of the startups have already raised anywhere between 100,000 and up to 60 million pounds. And probably now we've got about 25 to 30 of those with products on the market. To give you an example, one of our junior doctors called Krish Ramdu, he was an ENT surgeon, but he had a very unusual PhD, which was in earwax. And I don't think there are many people who can claim to have such a PhD, but of course it's a real problem. You know, 500 million people across our planet have hearing loss related to earwax. And of course, ear syringing is not recommended by NICE in our country anymore. So he took a very simple solution. Lots of companies have been trying to solve this problem. And he took a smartphone and created a little ear speculum that you could clip onto that and just hack the camera so that it focused down the ear speculum. You didn't need any new optics or anything else, and used a bit of artificial intelligence to help improve that image. And so good is the image that just by clipping this onto your smartphone, you can not only inspect the ear, but you can also train healthcare assistants to remove the earwax just with standard suction techniques. And so he had to leave ENT surgery. He raised £1 million from a family office based in London to take this idea forward, and he came back as a GP trainee under the Entrepreneur Programme. He now has a national contract with Boots, the chemists in the UK. He signed a deal then with Walgreens as well. So they are rolling this test out for everyone who comes in for a hearing test in the Boots Walgreens Alliance. Within the next year, you will all have the SEEK kit, as it's called, the Community Ear Examination Kit, to do your ear inspection and suction of wax. But he's also in discussion with a number of big tech companies who will be very well known to this audience, but most importantly companies like Oticon, who are the largest manufacturer of hearing aids across the planet. So this is now a trainee GP in North London who's developed a device that's world leading, and actually depression, falls, dementia are all linked to hearing loss. So he's having a massive impact, and if we hadn't have had this programme, he would have left healthcare and would have lost that amazing frontline talent, but we've kept him in. So I think we've kind of unearthed this thing where it was bubbling up under the surface. I've seen it. I arrived in Germany yesterday. We've had some meetings. I'm at the Ministry of Health, meeting with people tomorrow. And I'm seeing, and we were at the Charité Hospital yesterday, and they have a conference there today with 500 people looking at healthcare entrepreneurship there. So it's not just in the UK or the NHS. When I've travelled to Israel or to the United States or parts of Asia, this theme of supporting entrepreneurship and frontline clinicians getting involved with it, not just leaving it to industry.
I was going to say very much coming up from the front line. Because do you think the digital health sector in general is coming up with the right ideas? I mean, we heard on the last panel that there may be some cultural dissonance, particularly when US, perhaps in China, players seek to sell into the European health systems. Your programme is one way of avoiding that, because these are people steeped in the NHS. But beyond the people graduating from your programme, do you think there is still something of a dissonance there at times?
So I think I'm not so sure I have all the right answers, but what I would share with you is some observations I've seen in my role. I'm not aware of another clinician who leads a whole nation's healthcare innovation, so I get to travel across the world and observe different systems. And what I've observed in the United States when I'm there is this process of they will try almost anything, they'll give it a shot, they have a real can-do attitude. And that's a bit like evolution in a way. It's a sort of a launch and learn type thing, where we'll try hundreds, thousands of different opportunities, and there'll be one little mutation, it will be an evolution, that makes a difference and a change, and then they support that and it grows forward. And when I've, in the last sort of 24 hours I've been here in Germany having various discussions, Germany's almost to the other end. It's a plan and perfect type approach. Before, certainly when I was with the GBA, I think it was yesterday, they were saying we have to have the evidence, we have to have the data. We heard the minister speaking about it, and quite right too. This is healthcare. We have to proceed safely. But there is a paradox there, isn't there, between how can we adopt the latest, greatest things in a rapid and safe manner and have the level of evidence we need. But actually we can't wait 5 or 10 years, because these apps, these other digital health products are changing on a day-by-day, week-by-week basis. So I think you need to bring new thinking and new action. So I think we've kind of found a halfway house in the National Health Service with our innovation strategy in saying randomised double-blind controlled trials serve their purpose and they're really great things, but there are probably just 2 or 3 I'm aware of that have been done well in the digital health space to any scale, and that's nothing compared with pharma. So actually, do we need to use different forms of evidence? So instead of, we always used to talk in traditional medicine about evidence-based practice. And I would turn that around and say what we need in the future is practice-based evidence. So how we learn from what's going on in practice out there, take that real-world data and bring that together. So I think there is a dissonance. There are lots of things coming forward, but I think a combination of the American approach, launch and learn, but if you just have that and you don't have the thoroughness of the standards that I've seen here in Germany and in many other European countries to make sure it's safe. So you need a combination of the two, and it's not just clinicians, it's patients as well that need to be involved with as citizens, user groups and others, because to think I'm, as you know, the clinical lead for innovation for the NHS, is going to come up with the latest, greatest things that are going to change it. No, we need to provide the framework and the infrastructure so that a whole range of different people. So there's a great example, a patient who had a bowel transplant, total bowel transplant, and before that he'd had a stoma bag for many years. And I've made many stomas in my time as a surgeon for patients, but never once had I thought that a stoma bag that explodes was a problem. But if you're a patient who's had one, it's completely unpredictable, it's terribly embarrassing, you could be in any situation. So he was really motivated, so he developed his own app. He took a little flexible element out of I think it was a Nintendo Wii game he took the technology from, and designed a clip that goes on the stoma bag that alerts your smartphone when it's half full. So you can just have a gentle vibration in your pocket, you know you need to go and empty your bag. Now, I've been doing this for years, I would never have thought of that, and industry hadn't come up with it. It took a patient to
come up with it, right. Yes, so patient entrepreneurship, not just clinician entrepreneurship.
So we are, from next year, the NHS plans we wanted to get it tested and trialled and get it right, but we want to get our first patients on our programme too, because only if we bring everyone to the centre will we redesign and get the healthcare system we need for the future.
So interesting. I mean, if you sort of look at the very seamless process for adopting new medicines, you've touched on it already, from research through large randomised clinical trials to evaluation to uptake, we still don't have quite that seamless path for digital health technologies.
Are you applying for a job in the Foreign Office? That was very diplomatic. I think saying we don't quite have a seamless path, it's totally different. What we designed for drugs is not necessarily, and in my opinion, doesn't serve the same benefits and the same purpose we've got for digital health. So to give you an example, a few years ago, we decided we would try and take on app assessment. Many countries in the world had taken the view this was too difficult to do, in the United States, some European countries too. But the NHS stepped forward and said, we're prepared to trial this. We came up with an NHS, what we called endorsement process, where we would try ourselves, working with our colleagues at NICE, the MHRA, NHS Digital, to try and actually set a standard for apps. There are over, at the last count I was told, over 360,000 healthcare-related apps on the Android and Apple stores. And yet, where is the guidance for the population who are out there downloading these, using them? Are they safe? Are they not? How do we know? It's almost like sort of the Wild West out there in some ways. So we made this very bold step to say we will try and take this forward and do something. And our first attempt didn't work. It didn't. It was overwhelming. But what we found.
Why was it overwhelming?
Because with 360,000 apps that are changing on an almost daily basis, how can any human being actually do something? So then we, through the ecosystem in the UK, a couple of companies stepped forward, one called Our Mobile Health and the other one called Ulka. And these are digital app assessment companies. So one of them was a frontline speech and language therapist, and the other one a company that had just got some real insights into how we might do this. So they dissected the apps, they looked at how they were coded, what the security features were, how they shared data, what standards of clinical evidence they had used, and then they gave them a score. And what they did was they picked the top 50 conditions, they looked at the top 10 apps that were being downloaded and regularly used in those spaces and just started by assessing them in that way. And by doing that, they've now, between the two of them, assessed tens of thousands of apps. So NHS England have commissioned and worked with these two organisations to help us with digital app assessment. And as far as I'm aware, this is the leading example of a government taking a step into this area. So we now have our NHS England App Store. So we've got, I think, around about 100 apps that have gone through the process to a standard with evidence, which we think, as a healthcare system, we should be supporting. And they're in a number of key areas, but it's a work in progress. But the really interesting thing, when I was speaking to the chief executive of Ulka recently, she's now working with 5 or 6 foreign governments, some in Europe, some abroad, to help them develop their ideas and take this forward. So thinking an answer would have come out of the centre of excellent organisations like NICE, the MHRA, NHS England and NHS Digital, wasn't the approach that gave us the result we wanted, but working in partnership with disruptive startups who could think in different ways than we were, and we got the best of both worlds, and now we've at least made a step forward. It's not perfect, but I think it's better than nothing. So people get a rating from 0 to 100 on how safe that is. I don't think any app has scored 100 yet, but you know, if it's less than 10 or 20, your data is going to be shared, there's not much clinical evidence using it, you probably shouldn't be considering that. So it helps to give advice and guidance to inform patients about what we think of how that digital health product has been put together.
The NHS is sometimes seen as a difficult body to engage with for digital health entrepreneurs. You know, the idea of a sort of not invented here spirit, the enormous fragmentation of the system with so many different procurement points. How do you respond to that? I mean, do you think that's a fair characterisation? You must hear this quite a lot, I'm sure.
I give therapy to lots of startup companies all the time who come and tell me of the difficulties of life in this space. So it's not easy for a variety of reasons. It's not easy when you're a company trying to take forward digital health in any healthcare organisation. We've certainly heard the difficulties in Germany, hear of that. But I think we've got, my chief executive's been in post 5 years now, and he's taken a new approach to these things in how we might sort them out. He's put a number of building blocks in place that are making a culture, that are turning round the sort of healthcare supertanker that the NHS is, to become more agile and adopt things more. And I was really interested. I was at a dinner with some investors and venture capitalists about a month ago, and this exact question came up. Someone was saying, oh yes, but the NHS never buys things. And someone who just made about a 5 million investment in a digital health startup in the diabetes prevention space turned around and said, no, it's changing. The NHS is now one of the leading healthcare systems for adopting digital. And they gave the example of the diabetes prevention program. So a set of 3G scales connected to a little app with a social network where 10 or so people could come together with a dietitian for half an hour a day, talk about their meal plans, but also they could stay connected for the rest of the day on this. And that brought together the sensor technology with the social network platform and a curator who was an expert in that space. And our 1 year results, we commissioned 4 companies to deliver this program at a small scale to test it and trial it nationally. And at a year, the data was starting to show about an 8 to 10% sustained weight loss for these patients, which was transformative for them. And they didn't want to give the up and the little social network. They didn't know who the real people were. They were all just virtual people. And so we took the decision, okay, we're going to commission this nationally. So now we've rolled that out, we've put our money where our mouth is, and we now have a national diabetes prevention program based on that. So companies are saying, you are starting to do that. And let's look at the wearable glucose sensors. Devices like the Lifestyle Libre device from Abbott, tissue glucose monitoring. We're commissioning that nationally to make it available for patients. So you might say, and the argument very much from the clinical world was, there aren't randomized controlled trials to say that these wearable glucose sensors give us the same result as a blood glucose level. Well, you're absolutely right. It doesn't give us the same result. But you know, the insights it was giving patients. The most wonderful thing for me was I met a child who got type 2 diabetes. And the thing I just hadn't realised, that the thing that upset them most was every night their parents have to wake them to prick their finger in the middle of the night. So the parent has to wake up, the child has to experience pain to check their glucose. And this monitor transformed their lives. Their tissue glucose level was monitored, the child could sleep, the parent could sleep, and they could be alerted on their phone if there was an issue that needed some kind of intervention. And when patients were given this technology, they started to see what changed their glucose level. So knowing your absolute blood glucose level wasn't so key. It was the trend that emerged, the shapes of the curves. So they could plan what they were eating, plan their exercise, plan their day around that more and more. So it's still early stage, and we had a lot of hearts and minds to win amongst the academics in endocrinology and clinical medicine. But in fairness, many of my colleagues have now stepped forward and are champions for this. So I think sometimes we're doing things in slightly different ways and we can utilise technology. And you know, when you've got a health service that's prepared to commission things like that nationally, as well as putting in, we have something called the Innovative Technology Payment Programme, where we go for calls every year to the world for the latest, greatest technology, and if it stacks up and we look at the evidence, even if it's quite early stage evidence, we will commission those things nationally. There are several things, so HeartFlow, which is the sort of AI machine learning system out of Stanford, looking at whether a coronary stent is going to be of benefit. We've commissioned that and rolled that out nationally across the NHS. So we're changing things around. It's slow, but we're putting the right building blocks for culture in place to make that happen. And so I think we are embracing those challenges, and so I'm really proud that we are turning the ship around on that.
Fantastic. That's a great note on which to end, and we are out of time. So thank you so much, Tony.
My pleasure.
Now we're going to break for coffee. Could you all be back in about 20